Respected chair and delegates, wish you all a very good afternoon. So I would like to thank AIOS Scientific Committee for recognizing this paper and choosing it as the best paper at the last midterm conference. So I'm Dr. Mithun Tulsidas. I'll be talking about corneal tomography in fellow eyes of unilateral keratoconus for detection of subclinical keratoconus. I have no financial interest, so I would like to share my brief experience on how I thought of doing this study. So, does unilateral keratoconus really exist? So, that will be a question which most of us encounter. But when you do a literature search, you can say that true unilateral keratoconus is a very rare entity. So, keratoconus is mostly a bilateral disease with an asymmetrical presentation. So when one eye manifests as keratoconus, the other eye must be the earliest form of keratoconus or maybe a subclinical keratoconus. So what if we can find some parameters which can distinguish these fellow eyes of unilateral keratoconus from the normal eyes? Then obviously those parameters might be the earliest indicators to detect an abnormal cornea or keratoconus. So that was the main thought process behind this study. So studies suggest that subclinical or clinical keratoconus is found in 1 to 6% of the myopic patients undergoing refractive surgery. This is mainly due to one reason, because the detection of the disease in the preclinical stage is difficult. So this is a good pictorial representation which actually defines some of the terminologies. As you can see, the yellow arrow, that is actually the topographic parameters. So there will be a cutoff beyond which, if certain criteria are met, we term it as keratoconus. And as you can say, keratoconus suspect needs some tomographic features to be fulfilled, whereas in a forme fruste keratoconus, it can manifest even without much of tomographic features, and both come under the category subclinical keratoconus. So a forme fruste can be a false negative which might be missed even with the current screening techniques, and sometimes we might overestimate a case as keratoconus too. So the purpose of the study was to analyze the tomographic changes in fellow eyes of unilateral keratoconus patients by comparing them with normal eyes. So this was a 5-year retrospective comparative study, and patients with unilateral keratoconus diagnosed by Pentacam and normal candidates of refractive surgery were included. So there were 3 groups, one group with advanced keratoconus eyes, and the another group with normal fellow eyes, and the third group with normal candidates. And you might be thinking about the smaller sample size, but in this study we have exclusively included only those eyes in whom the fellow eyes are absolutely normal. That is, even it is clinically normal and even with a D value less than 1.6. And the examination was performed using Pentacam, and all the maps were compared. These were the statistical methods used. So 64 eyes were retrospectively analyzed, and the keratoconus manifested mainly in left eyes and in male patients. So these are the 5 parameters which actually showed a significant difference between the fellow eye and the normal group. Now we have plotted an ROC curve just to find which parameters can actually distinguish the fellow eyes from the normal eyes. So these were the 4 parameters with an area under curve more than 0.7, that is the D value, D thinnest point displacement, and pachymetric progression index maximum. You can see they have good sensitivity, however the specificity is little on the lower side, and this was the first data ever in the Indian population. D value and PIVAX were the most characteristic indices in our study in discriminating fellow eyes with normal eyes, similar to the few studies done by Vasquez et al. And Hussain et al. However, ours is the first study to have such data in Indian population. We do have a limitations of a small sample size, but as we all know, the incidence of a true unilateral keratoconus is very rare. Thus, this is unlikely to skew the results of the study. However, further studies with a larger sample size and simultaneous evaluation of the recent corneal biomechanics and wavefront aberrations may be more useful. To conclude, bad D value and pachymetric progression index were more effective than other Pentacam parameters in detecting the earliest form of subclinical keratoconus. And yes, the present study supports the usefulness of Pentacam. However, a single parameter alone is not enough to detect early changes. We need a combination of data. Thank you for your kind attention.
Thank you. So, is Pentacam the best machine to assess keratoconus?
No, sir. Right now, we have the corneal biomechanics and wavefront aberrations also in the picture.
Yes.
So we can also use those machines, like even a Corvis ST. which is
Yes.
found to be, you can actually do a combination of things, not a single machine.
Yes. And what is the latest in assessment of keratoconus?
No, sir, like this is the machine which we had in our setup, but yeah, we can always use a Pentacam HR with a bad map with the third bad map. Bad map 3 is the latest one, which actually includes an ART max, a K max, and elevation at the thinnest point. So if we have a latest machine with inclusion of bad 3, because this was
What
done,
is ART?
ART is Ambrosio relational thickness.
Okay.
So if this is basically including bad 2 maps, this study was done. So if we have a bad 3 map coming in the picture, then it would be given more clear picture.
Is epithelial mapping helpful in keratoconus assessment?
Definitely, sir, definitely. I have not done a study or I am not familiar with it, but
No, no, no,
definitely the
that's
studies say
that's the
epithelial
latest
mapping.
concept
Yes,
in
sir.
keratoconus
Yes, sir.
assessment.
Yes.
Yeah.
Thank you.
Thank you.
Thank you.